So I think to our GU cancer cousins, as far as prostate cancer and kidney cancer, where we have very robust data for metastasis-directed therapy with radiation. I think of prostate cancer as being, one of the highest level of evidence of almost any malignancy out there for the use of MDT. When we think about bladder cancer, there's really low level of evidence. However, and part of the reason why MDT had previously not been utilized for bladder cancer is that many times when we were dealing with metastatic disease, it was very frequently polymetastatic. It was not oligometastatic. And the reason for that is once patients no longer responded to cytotoxic chemo, there really wasn't a lot available to them, and they became polymetastatic very rapidly. It was a rapid progression. There was no window of time to even discuss metastasis-directed therapy. But what has changed over the past 5 to 10 years, we've seen the advent of both immunotherapy and Enfortumab vedotin and these very important antibody-drug conjugates. And what has that done? That has provided that window. We've seen patients now plateau in their disease response. We've seen a very good window of time where patients are potentially developing some toxicities from their systemic therapy, but their disease is remaining stable with maybe just a few sites of oligoprogressive disease. And that is where radiation can really shine. We want to ideally be able to provide the patient the benefit of either continuing their same line of systemic therapy or having a treatment break for those patients that are developing some degree of toxicity. And if we're offering metastasis-directed therapy for those indications, I think that's where it really can shine for bladder cancer, as we're seeing such great improvements in systemic therapy for our patients.